for coming. I am Gino, Chiappetta, spine surgeon with the University of Orthopaedic Associates. Matt McDonald, my partner here as well. Spine surgeons with Robert Johnson, Rutgers University Medical School as well, with the Department of Orthopedic Surgery. So today, we're going to talk about a topic of cervical disc herniations, and particularly cervical disc replacement. It's a newer technology. My disclosure is I have no financial investments with any companies, no financial investments with LDR whatsoever. This is just purely based upon science and what the data shows in our personal experience. So with cervical disc replacement, the new data has recently come out, and currently in 2016, right now cervical disc replacement has been proven a good option for two-level cervical spine surgery. So patients with two-level cervical disc herniations, stenosis, right now are indicated for two-level cervical disc replacements, and the insurance carriers are starting to accept that as being a standard of care. So, that is the name of the cervical disc replacement that's made by the company LDR. It is indicated for skeletally mature patients for reconstruction of the disc from levels of C3 forward down to C6, 7. For 1 or 2 continuous levels who have failed 6 weeks of conservative care or have progressive symptoms. So typically patients who have a C2-3 disc herniation not indicated, cervical thoracic junction not indicated, anywhere from C3 to C7. So there are approximately 1.1 million patients each year in the U.S. that suffer from symptomatic cervical disc disease or disc herniations. It can have significantly affected a person's ability to sleep, work, drive, all the quality of life issues, including personal life, work, and all those things. Answer for relief of pain in many of the patients have been neck fusion surgery, dating back even prior to the 1960s. Dr. Cloward was a neurosurgeon in Hawaii who was one of the pioneers of cervical surgery back in the 50s and 60s, as well as Smith Robinson and several other orthopedic surgeons. So in the early 2000s, research and development for cervical disc replacement began with the proliferation of designs and entering rigorous clinical studies. Biomechanically, there's a lot of issues that go into this for wear, just like hip and knee replacements. There are artificial surfaces, so you look at wear characteristics, catastrophic wear. Will this thing last with patient's life? So if someone in this room had a cervical disc replacement in their 30s, what's going to happen when you're 60? Will it last? So these are biomechanical studies that need to be addressed. So between the years of 2009 and 2013, the FDA approved 6 disc replacement devices in the U.S. All the devices compared the clinical results to neck fusion. So basically, 6 device maker companies, whether it's Medtronic, LDR, etc., had come out with their own version, and then they kind of tested them compared to ACDF, or single-level spinal fusion. And so they have to look at the results. But we said there's nothing worse for results than long-term follow-up, right? So how do things do 5 to 10 years down the road? And that's the big question. So most of the presentation is neck and arm pain. Typically, I tell people, you think you're just like a jelly donut. When the disc breaks open, you typically get neck pain. Then you get radiculopathy or arm pain when the disc comes out of place and compresses the nerve. Hopefully it's not spinal cord compression, but the nerve root compression will cause arm symptoms, usually in the dermatome at the level of the disc herniation. So every time you see a patient, say, is it your neck bothering you, is your arm, both, how much, both arms, one arm, is your leg? So all issues, difference of just neck pain versus arm pain versus both. So with neck pathology, obviously with aging, the intervertebral discs will all dehydrate with time. Some people have degenerative disc disease, more accelerated due to genetic predisposition. Some people have remote neck injuries from playing sports or car accidents that may predispose patients to have more accelerated disc degeneration. So basically, here's the jelly, the donut coming out of the disc, compressing the exiting nerve root here. And obviously, due to the confined space, you'll have significant nerve root compression and arm pain. So the patient's symptoms and effect of daily life. The biggest thing with that people is sleeping. People can't sleep at night because of pain. That's a huge issue. Do you have pain, weakness, all those kinds of things? Can you do your ADLs? If you have children, can you care for your children, pick up your kids, can you drive? All those things. So all factors that come into it. So, things you look for, pain in the neck, neck stiffness, say I have a stiff neck, decreased range of motion, numbness, tingling, or weakness in the arm or hand. Is it their dominant side, the right arm versus the left arm versus both arms? weaker absent upper extremity reflexes, weakness of lower extremities, any effects on the walking gait, huge issues. We always ask for bladder and bowel function, because that could be a signifier of any spinal cord irritation and compression as well. Headaches are pretty common. Headaches are the second, one of the most common complaints with neck issues because of extensor muscle irritation and spasm. Headaches are pretty common with these. There are actually studies that show significant improvement in neck pain after cervical surgery, and with concomitant neck and arm pain as well. So if patients ask, will my headaches go away? Unless you have migraines, aside from that, yes, it should get better. So common effects that function in daily life: difficult driving, turning of the head, which is a big issue. Difficulty lifting objects, the women with their purses, men with laptops, or if they're working construction, or their manual labor. Difficulty working, reading, concentrating quickly. In this day and age, computer work, is a huge issue. Difficulty with personal care. Older women, can they raise their hand to do their hair? Can they brush their teeth, put on their makeup, eat, all those things. Effects on recreational activities, exercise. Weekend warriors, people, just going to the gym and exercising, can they run, and issues like that. So what are the options for treatment? So typically we have the standard initial treatment regimen. Usually the first 6 weeks, try to cool them off. Let's say severe pain or severe progressive neurological deficit. So try rest, activity modification, physical therapy, controlled exercise, stretching, bracing, in conjunction with anti-inflammatories, Aleve, Advil, Motrin. Some analgesic medications, muscle relaxants. If they have real bad pain, sometimes steroids can be helpful, or oral steroids for a short course can help with radicular pain. Chiropractic treatments and traction are great. Sometimes stretching of the neck can really help offload, and some manipulation with chiropractic care is also indicated very commonly, and we try to refer out as much as possible. So pain injections and blocks can work well. Sometimes people have severe pain, they can't sleep. Instead of going through all this, going through 1 and 2, we'll go right to 4 and 5. See a chiropractor, get some manual traction, see one of the guys that pain management, get an epidural injection, see if we get your pain under control. Acupuncture, there are some studies, it's like plus or minus, whether you believe in it or not. I say, listen, it can't hurt you. If it works, you can't argue with success. Whatever works for you. So, let's talk about surgical management. So what are some surgical options? So how many people know who Peyton Manning is? Yeah. Some people know Peyton Manning had cervical surgery, or multiple spine surgeries. So he had 2 or 3 of these, okay? He had 2 or 3 limited laminotomy, foraminotomies for micro decompression of his exiting right C6-7 nerve root, and guess what? It didn't work. Because it doesn't always work, because if you have disc degeneration, it's not going to work. If you have a soft disc herniation in the lateral in the foramen, this may be an option if someone has no neck pain and no disc degeneration. So laminectomy, which is a posterior-based procedure as well, removing the pressure on the spinal cord, from removing the ligament and flavum and spinal lamina, is an option as well. Usually laminectomy is the one answer on the boards that you're not supposed to choose. It's like, if they say laminectomy, like cross it off, it's usually never the right answer. Because most of the compression is anteriorly from the front. This is coming from the front to back, compress the nerves, so decompressing posteriorly. Usually wouldn't do a whole lot. So the surgical management, the gold standard of care for 60 years is, we call anterior cervical discectomy infusion, or ACDF. So 1, 2, 3 levels can be outpatient procedures in young patients. There is extensive studies on ACDFs for decades. The patients do very well. So the results for patients for a single or 2-level ACDF for relief of back and neck and arm pain is over 90%. So then you're trying to challenge this with the new technology with disc replacement. So how do you beat something with over 90% success rate? So it's a tall order. So with an ACDF, you approach the spine anteriorly from the front. After you move the structure that way, access the spine, you remove the offending discs. The disc spaces that are removed are filled with either wedges of bone or allograft, sometimes spacers with allograft. Then, the vast majority of the time, a titanium plate screws is placed to fix the levels, that gives you some support, which will stabilize levels, allow early neck range of motion. The pressure's off the spinal cord, the arm pain goes away. As the discs fuse, the neck pain gets better. Patients typically have over 90% relief of their symptoms. So, fusion has been used successfully for more than 50 years and is very familiar to most spine surgeons. However, fusion changes the normal biomechanics of the cervical spine. So what can be the long-term consequences? So people have an engineering background. Obviously, if you remove some degrees of freedom and motion levels, more stress to discs above and below, more advanced disc degeneration will be a problem in the future. And those are questions asked all the time by patients. All the time. So, surgical disc replacement. So basically, the great thing about this for surgeons is that it's the same exact surgery as an ACDF, except once you take the disc out, you put in a prosthetic disc versus a fusion device in a plate. So a disc replacement procedure can either be inpatient or outpatient instead of fusion, where the bulging disc is removed and neural structures are relieved from pressure and pain. Then the cervical disc prosthesis is placed in a disc space. It restores and maintains the disc height, like on the lateral view here, while allowing natural motion to continue. So instead of taking the motion away, we've done the job of removing the offending agent, which is the herniated disc, but now we've maintained motion of the cervical spine. So it's been used for more than 20 years globally. All, when you read spine literature, all stuff eventually starts in Europe and Asia, and eventually comes to the U.S. because the FDA regulations are much more stringent. So this was, LDR is a company founded in France. So this has been available in France for 20 years. There's been some refinements of disc replacements from LDR and other companies with better technology, and there's been long-term data published for this. So there's good studies. So we look at, okay, so if someone has a 2-level disc herniation on one level, are you going to do a disc replacement or are you going to do a fusion? So say you have a fusion here like C5, 6, C4. So if someone had a fusion in 1977, the disc looked great. 7 years later, 84, you see some narrowing. 89, you see they went back and had another fusion. So the big question is, if I have an ACDF for a disc replacement, I'm probably going to get the job done with relieving the pain and make them feel better. But will I prevent them from needing surgery again 10 years down the road? And that's the big question. So multiple clinical studies of comparing fusion to disc replacement have shown up to a 5 times higher reoperation rate for fusion patients. Okay? So you have a 5 times higher chance of needing additional surgery, either short-term or long-term, as well as increased radiographic adjacent level degeneration for fusion patients. So if you take 100 patients had a fusion versus an ACDF, 1 or 2 levels, 5 to 10 years later, those patients that had a fusion will have narrowing of the disc above the fusion versus much more significantly versus the patients who had a disc replacement due to the biomechanics. So looking at the clinical results, okay, I always tell them, I said, I don't want to hear about this, just show me the data, show me the science, okay? So disc replacements are designed to maintain physiological motion and minimize downsides of fusion. So the IDE, which are the investigation of the device exemption, those are the sentinel first studies done on the patients. So they've shown disc replacement versus fusion. So they've shown a less radiographic adjacent level degeneration, almost 3 times less with disc replacement, fewer reoperations by almost 5 times, better disability improvement up to 16.5% better, maintenance of motion up to 2 years from surgery, faster return to work up to 3 weeks faster. Why? You're not waiting for anything to fuse. The disc replacement has motion, so move your neck. So MOBC, the history and design. So biomechanics is huge for disc replacements, okay? There have been a number of companies that have made disc replacements, obviously, but the design is critical for this. So, like I said, LDR was first, it comes out of France, so it's designed by an experienced French surgeon team. The first implant was in 2004 in France. It entered into the FDA trial for 1 and 2 level studies in 2006, and over 30,000 of them have been implanted in over 25 countries, including the U.S. So the MOBC designs, there is a actual MOBC prosthesis up here, so if you want afterwards you can take a look at it and see what it looks like. So what are the key results of the MOBC FDA trial? So this is the key, because FDA trials are double-blinded studies. So these are really good design studies. So it was studied at 24 centers in the U.S. of 59 different surgeons. That's almost 600 patients with 1 and 2 level studies. 647 of the MOBC disc replacements were implanted. So the patients were randomized. They didn't know if they were having a disc replacement or a fusion. Okay? So the 2 results were submitted to the FDA product protocol, and study patients were followed for 7 years. And MOBC received FDA approval in August 2013 for 1 and 2 level indications. This device is the only device that's been FDA approved for 2 level surgery. So what are the clinical outcomes? How do they do? So the patient's x-rays were analyzed at every study visit to evaluate disc height and bony changes compared to baseline for the adjacent levels. The 2-level patients had almost 3 times less adjacent segment degeneration than fusion patients throughout the 2 years. So if you look at here, we said a 2.9% versus 18% versus 13% and 33% at the superior level. So this is huge. So a 20% higher rate of adjacent segment disease at the disc right above a fusion, a 2-level fusion versus disc replacement. So that's big. So secondary surgery. So patients say, is this going to fix me forever? Well, I need surgery again. Well, so patients at 2 years from surgery with the OBC had a 3.1% chance of having another operation. If you had a fusion, you had 11% chance of having another operation. And 11.4% encompasses everything. Adjacent segment disease, failure of fusion, hardware complications, subsidence of the graft, and all those things, reoperation from hematomas, reoperation from esophageal injuries, so various things. So patients' x-rays were measured for flexion and extension views and side bending angles to see how much motion did they have at 2 years post-op. So the patient had a disc replacement had improvement from baseline maintained throughout the entire 2 years. Okay, the motion in a physiological range for the 2 years was maintained. So the green bar up top here shows the motion down here. The fusion level shows decreased range of motion. So a big difference. So what was the NDI score, the neck disability index that we usually calculate? So the NDI was scored at every visit from baseline to 2 years post-op. Patients answered all the questions of the NDI, which really goes to disability with driving, lifting, recreational activities, personal care, reading, sleeping, concentration, work, pain intensity, and headaches. So he calculated a base of 100 points. So at 2 years, the patients have disc replacement for 2-level disease had statistically significant better disability improvement versus fusion patients at every time amongst the point. You can see here the green bar on the right is for ACDF, lighter green bar on the left is for OBC. At each level, the OBC disc replacement did better than its counterpart, and every level was statistically significant. So the number of days of surgery until the patient was able to return to work. Everyone says, when can I go back to work? When can I drive? So if you had a 1-level fusion, people were back to work on average at 36.8 days, so about 7 weeks. If you had a single level disc replacement, about 29.3, so about 1 week sooner. If you had a 2-level fusion, you're out of work about 66 weeks, okay, so almost 9 weeks, a little more. OBC, disc replacement, 45.9, so 3 weeks sooner you got back to work, which is huge in this day and age. I mean, 3 weeks of difference, it's a huge hit in your paycheck. So 1 week faster versus 3 weeks faster for 1 versus 2 levels. So, very encouraging. So, with all 5 components of sign, so the FDA has its criteria, what gets approved and what not gets approved. It has 5 criteria. So, radiographic success, neurological success, that they have better outcomes with arm pain, strength, numbness, that any abnormal reflexes, NDI improvement with the score we saw before, no device-related adverse events like any catastrophic failure of this device, as well as reoperation rates. So fusion patients were successful at 1 level, 65.3%, OBC 73.7%. At 2 levels, fusion success at 37.4% and 69.7%. Statistically significant compared to the counterpart, especially at 2 levels, huge difference. These are very stringent criteria, that's what the numbers are. So the efficacy of fusion decreases when the number of levels is increased. So you go from 1 to 2, huge difference. Here, not much difference. So now we look at the study conclusion. Non-inferiority to fusion at 1 level. There is a statistically significant superiority to fusion at 2 levels. So look at the OBC, 70% success rate at 2 levels at 2 years, 37.4 ACDF. That's a P of 0.001. So that's extremely statistically significant compared to a 2-level ACDF. So basically, OBC prosthesis is the only prosthesis on the market that's FDA approved for 2-level surgery. All the other, there's not one other implant that's been approved for 2-level surgery. There's not one other implant that has any of the studies that show improvement at 5 years for 2 levels. So we look at things like success rates early on, radiographic outcomes for motion, radiographic outcomes for degeneration above the level. So the disc replacement is far superior with the data at this point compared to the 2-level fusion. So contraindications, who shouldn't use it? Patients with cervical instability for more than 3.5 millimeters of motion on flexion extension views, not a good candidate. Increased motion, increased wear, better to fuse them, okay? If you have risk of osteoporosis, older patients, if you have weak bone, if you implant a device like this, there's a good chance that the hard metal will subside into the vertebral body and cause catastrophic failure and wear and cause abnormal mechanics of the spine. Anyone who's had like osteomyelitis, a chronic infection, or has a current infection elsewhere in the body, not a good indication for any surgery whatsoever to the spine. So compromised vertebral bodies, so if they've had previous trauma, abnormal end plates, they're probably not a good candidate because if you have to do a lot of bony work and take down a lot of the end plate of the vertebral body, this thing can subside and fall into the vertebral body and go into catastrophic wear. So if someone has a known allergy to metal implants, cobalt-chrome, molybdenum, titanium, not a good candidate. If someone has severe facet joint disease and degeneration, usually you'll see very severe collapse. Probably better just to fuse them. It's hard to get back motion in a patient who has a very severe facet disease. It won't overcome that, and the extra stress on the facets will just cause more neck pain. So might as well just fuse it and stop the motion at the hypertrophic facet levels. So these are all, this is all the studies. There's been excellent studies done. They're all published in, very reputable spine journals, and peer-reviewed journals. So this is purely based upon that. So Obc again is the first and only disc replacement prosthesis approved for both 1 and 2 levels. So we'll show a little video here. Unfortunately, it's not on YouTube.
The internet just dropped. So I'll go here. I'll go back to the video.
Okay.
That way.
So I'll do a little case presentation here myself in a minute. So that's me. So this is a 30-year male. This guy had 2 prior ACDFs. So he had an ACDF in 2007. He developed a disc herniation facet fracture after a skiing accident and had a single ACDF at C6-7. Did well. I saw him back in 2010. Had adjacent segment disease. Had a subsequent ACDF at C5-6. So this was him before his second ACDF. So he had a cervical fusion here at C6-7. Some narrowing here, C5 here. Here's the axial view of C5-6. We see a fairly large disc herniation. Here's your spinal cord. Typically, we like to see cerebral spinal fluid surrounding the spinal cord at all levels. Here he's got pretty bad spinal cord compression, more of a right-sided disc herniation causing neck and arm pain and radiculopathy. So I went ahead and did an ACDF on him above at C5-6. Did very well post-op. His symptoms resolved. By this time he's in his early to mid-30s. Did great. Went back to work, exercised, and fine. Comes back to see me in 2013. He says, "Doc, when I'm exercising and lifting, I have numbness and weakness in my arms. I'm doing triceps, I'm doing biceps, but I don't have the power like I used to. I don't know why." Okay. Every time he said he extended his neck to do some exercises or look up to see, to look high, he felt burning pain going to his arms upon neck cervical extension. So, okay, we get another MRI. So what do we see now? Does he have adjacent segment disease above? No. Right up here, C3-4. So 2 disc levels above, he now has spinal cord compression, disc herniation here, and here's the axial view of C3-4 with spinal cord compression here. So he has a herniated disc, severe stenosis at C3-4, which is 2 levels above his 2-level fusion, with a skip level in between. C5-6 disc is pristine, no herniation, no degeneration. So all right, listen, you're young, you have 2 surgeries, let's see what happens. They went for some physical therapy, had some anti-inflammatories, some pain medication, nighttime to help him sleep. Progressively worsened over time, over months. He just didn't get better. He was having a baby in the meantime. He was just busy. So you have your neurosurgeon in training here, or orthopedic surgeon with a scalpel in the hand, very excited to operate someone. But what do you do now? What are your options? So you can do another ACDF and keep your fingers crossed that the disc in between isn't going to break down. You can do a cervical disc replacement option. You can do posterior laminectomy plus or minus a fusion. You can do laminoplasty, which is a posterior procedure to give the spinal cord some. So those are all options. So for this patient, went ahead and did a cervical disc replacement here at C3-4. Maintained the motion of the disc by completely removing the disc, taking the offending agent, and leaving the skip lesion in between. Because he says to you, well, if we're going to fuse this disc, what are the odds of this one in between going to go, and how fast is it going to go, and need another surgery? And if so, do you just do a 2-level fusion now and take away more of my motion at the age of 38? Or disc replacement, good idea, bad idea? So, we went over to C3-4 complete discectomy with insertion of a cervical disc replacement. He's 18 months post-op, he has no symptoms, completely symptom-free, no neck pain, his excellent preserved range of motion, works out, runs, lifts, works at IT computers. So this is him 18 months out, cervical disc replacement holding up nicely, no adjacent second disease above or below his fusion at all. Good motion, these are flexion extensions, excellent motion at the level, good maintained. So we always say, you know, as a physician, especially as surgeons, this should be our Hippocratic oath, our prime purpose in life is to help others. If you can't help them, at least don't hurt them. We see a lot of patients that have surgery and say, well, what does this patient do to you? Why'd you hurt them? So, you know, what's the best option for the patient? So hopefully, you know, we take the patient's best interest at heart and, you know, do the right thing. Hopefully it works over time. And that's all I have to say about that.
That's great.
So now it's time for questions.
Okay, so Gino, so you, it sounds like most of the indication is radiculopathy.
Yeah.
Herniations, but it sounds like a perfect idea to replace a disc that's degenerated. So the whole phenomenon of discogenic pain, is that an indication for disc replacement? Or just
Well, I would say 95 to 99% of the surgery for cervical surgery is for radiculopathy or stenosis.
Yeah.
I think doing surgery on patients for neck pain is a very poor idea. I mean, it's not just me saying it, it's some studies saying it. There are no good indications. If someone does a 4-level disc degeneration, you do a 4-level fusion, what are the odds going to get better? Pretty poor. And the risks just don't outweigh the benefits. So
you
the
no
key.
longer need the provocative proof that you've got disc problems. This is more of a radiculopathy.
More radiculopathy. You know, I say normal discs don't herniate. Everyone herniates a disc has some level of degeneration, whether it's mild to moderate. Usually severe degeneration is herniate because no disc level there to herniate. But they have some, there has to be some weakening of the disc to herniate. So they have some level of degeneration. This is just mild. It was just dehydration. If someone has severe like collapse and stenosis, disc osteophyte complex, if you try to put a disc replacement in, you'll probably get their arm pain better, but now you're still allowed to move through their really arthritic facet joints. You try to distract this space open, it moves nowhere. It moves, and then on X-ray it doesn't look too bad. I tell you, when you go in there, man, this osteophyte's bridging the disc every time. You have to literally take down the osteophytes to get to the disc space where there is no disc. You take down all this bone to get to the osteophytes, and there's, you know, to put a prosthetic disc in there is just a very bad idea.
One of the surgical options with that is fusion.
And most of those patients are for like myelopathy or radiculopathy, severe stenosis. Not really, I mean, some patients will come in, yeah, maybe really terrible neck pain with a little radiculopathy with a really bad 1-level disc. Maybe I'll fuse those, but 3-4 levels, no chance. There's no chance.
If they're so degenerated, there's a lot of like bone spurring, significant collapse of the disc, but you gotta like take a burr just to get through the disc, dissect osteophytes. That's a bad idea to do a disc replacement because that's like an osteogenic thing, right? We're decorticating the bone, we're like promoting fusion, you know. So if you think you have to like burr down a lot of osteophytes just to get your decompression, I think in that patient it's better to do a fusion. And particularly they have a lot of neck pain. If it's soft, like a disc herniation, and there's not a lot of arthritis or degeneration, this is probably that's the perfect patient.
Like for me personally, I'm the kind of guy I dip my toe in the pool for a long time before I jump in. So, you know, I wasn't resistant, but I'm saying, like, you know, if things come out, I should try. I'm like, you know what? Let other people try and see how it goes. So, I wasn't resistant, but I was very hesitant.
You have to ignore us.
I was very hesitant because I say, I don't want to hear about the marketing. Show me the science. Show me the data. Show me unbiased data, non-industry sponsored studies, and let's see what happens over years. Because, like I said, the worst thing that happens for results is long-term follow-up. You guys all see the patient who has this great after like 2 days up, my leg pain was found in the epidural, they come back 3 weeks later and it's back, and it's like, okay, great. But the key thing is that if you have a cervical disc herniation, and they pulled people through the Cervical Spinal Research Society and SRS, would you have a disc replacement or a fusion? And it looks all over the map. Some people, many older patients, many older docs would have only a fusion, and all the younger guys would have disc replacement. So there's a lot of resistance in the community to some degree, but now that it's been very well proven, FDA approved, and accepted with insurances, it's been more and more reasonable to do. And the patients I've done have been pretty happy because I don't put people with neck collars, but some people do. But you don't have to wear neck collars for surgery. You promote motion. You don't have to worry about fusions occurring. You don't have to worry about plates being prominent, causing dysphagia. So it's like a knee replacement. You got your knee replaced, walk, bend your knee. We want you to. You got your disc replaced, bend your neck, dry, get back to work. So I think it just you kind of eliminate the whole need to follow the radiographic with fusions, to worry about adjacent segment disease as much as you did. And you tell them, listen, your disc went once, there's a chance one may go in the future, but if we do disc replacement, maybe we could slow that from happening rather than accelerate it. So maybe throw water on the fire rather than gasoline. So, I think for the right indications, it's a great option, but like anything in life, a bad solution to a problem gets bad results.
Do you have any post-op contraindications for it? Like you said, bending,
So I would not do it in someone who does collision sports.
Yeah, okay, gotcha.
So if someone's playing football, rugby, I would not do it. Basketball, let them play, baseball, those things fine, but not anything that's going to have any sort of wrestling, nothing like that. MMA, you're getting a fusion. See, the difference between cervical and lumbar disc replacement is this. When you're doing a cervical fusion, or an ACDF versus disc replacement, it's the same exact surgery, except you put in a disc replacement versus maybe a wedge of bone and plate. If you're doing a lumbar disc replacement, you have to go anteriorly. You have to have an access surgeon go through the abdomen versus a spinal fusion for L5S1 rather than disc replacement. You can do a posterior fusion all by yourself and not need someone. So the technology for cervical disc replacement is much more acceptable because it's the same surgery than like an ACDF versus a spinal lumbar fusion, which is always anteriorly, mainly at L5S1. So it really just changes the course. You have to get a vascular surgeon to do the approach for you. And so I think that's one of the big reasons why lumbar disc replacement hasn't really caught fire like cervical has. More surgery, it's just a surgeon kind of preference.
Chiropractic level, do people still continue with chiropractic afterwards, even if it's more muscular?
Yeah, I say listen, as long as you don't do severe manipulation, it's absolutely fine.
That was my next question. How, would you advise us to stick away from things?
I think soft tissue release and all those things are absolutely fine. You would have to, I don't know what the newtons are, but you'd have to do tremendous force to extrude. These are constrained. The polyethylene core is locked into the metallic plate. So it's not like this free-floating piece that's just kind of between. This thing is locked into the end plate. So you'd have to do some, you have to put in like a camel clutch or something, throw them off the top of the rope. You know what I mean? Off the turbo. You'd have to do something. Nothing you wouldn't do to someone who has a normal neck. So I tell people, can I just go to the chiropractor? Go for it. Makes you feel good. God bless you.
Do the outcomes show pretty much the range of that, or do you expect them to get back to basically?
Pretty much. So we look at functional range of motion.
Yeah.
There's nothing you need to do with your head like this, like in front of it. There's nothing to do with your chin touching your shoulder. Functional range of motion for driving, functional range of motion for work, computer work, doing anything with your family or something. So functional range of motion. If someone has a cervical disc replacement, even at one level of fusion, they have no discernible range of motion. I've had people with 4-level fusions with no discernible change in range of motion. 70% of your motion between occiput and C1 and 2. So all the rest of the stuff, not much going on. Usually the terminal extension than anything.
How far out have they gone so far?
Out of Europe, about 15 to 20 years. In the U.S., there are various devices. Probably, 5 years is the data, but the ID was launched like 06, 07. So there's probably 9 and 10 years data. It just hasn't been published.
How far out have you gone so far?
The first one I did was about 4 years ago.
So far, so good.
So I haven't had to take any out and revise it. And I haven't had to do any adjacent 7 levels. Now again, like I said, I was kind of slow to warm to the process, so I didn't jump right in. So volume will go up, from now going forward.
Like, with example, Tate Manning, you see like his arm strength deteriorate after the surgery. Sometimes I notice with fusions, I lose muscle strength. I see that with my fusion patients.
Sure.
Do you typically see that there's a lower chance of getting back to normal strength?
So in
does
the
it plateau?
initial IDE studies, the patient had disc replacement had a higher improvement of neurological recovery. They had a better recovery in motor function, sensation, and reflex findings. So they had slightly better strength post-op than patients had a fusion. We're just going to show a little video, just a little demonstration of the prosthesis and kind of get a sense of what it really is. So you can see here, so the polyethylene core locks, it doesn't lock, but it's pretty much, welded into this inferior end plate. As there's motion, the end plates and the superior end plate kind of slides over the polyethylene core. So that's why design biomechanics is so critical of these, because if you don't restore all their mechanics, you'd have catastrophic wear anteriorly, posteriorly, laterally. It's pretty high tech. If you look at the biomechanics, what's the force above and this is above and below a fusion versus disc replacement? And on studies, there's statistically significant increased stress force above and below the disc above a fusion versus disc replacement. And you cycle that for thousands of times and millions of times over years, you can imagine that's going to, eventually something's got to give. If you put 50,000 miles in your car versus 10,000, your tire's going to go quicker.
Why not just replace one of them then initially if you see some? Does that ever happen? Where you'll do a fusion and maybe replace it this above or below? Does that ever happen?
No, because
Just insurance approval?
if they have a complete normal disc, it's hard to say, hey, let's replace that.
Yeah, say it wasn't completely normal, but say you
And
see
yeah,
some.
you would never get insurance authorization.
Yeah, that's what I figured. Maybe.
That's a shame, because it's a good point.
There are what's called
Maybe you see the weight, like, say there's C3, C4, C5, C6, 7's gonna go.
right, probably.
Why not just do it right from the beginning?
Yeah. Something like that.
We call them annuity plans. So
Have you
there
ever
are
seen that though? Has anyone ever done that?
no, rarely.
No.
There are what we call hybrid constructs, which I have done in the past, which is a fusion at like one level below, and the disc replacement right above. So a fuse C67, disc replacement right above. I'm actually doing it in like 2 weeks only because if you have a pretty bad degenerated disc at C5-6 and radiculopathy, core compression, you fuse that level, soft disc herniation at one level above, do a disc replacement, maintain the motion. So there's not tremendous published data on it, but there will be, and the results will be much better than a 2-level fusion.
Yeah, I can imagine.
The one thing too, you see resistance that a disc replacement is a little more technically challenged than doing a fusion. Because a fusion, you put a piece of bone in plate, great. But this has to be perfectly placed, has to be perfectly centered on the AP, has to be perfectly centered on the lateral, so within 2 millimeters of posterior end plate. You can't violate the end plates of the bone. So it's very meticulous. So you got to be very, very precise when you're doing it. So it is a little more meticulous. It takes maybe an extra 10 minutes, 15 minutes to do, but it's worth it to prevent the patient from having additional surgeries in the future. So I don't want them to sound like, oh, the two surgeries are the same. This is definitely more technically demanding, requires a little more refinement and expertise, more fine details you have to pay attention to when you're placing it than a fusion. Let's see.